Olá, colegas, sejam muito bem-vindos ao Febrasgo Play, uma série de aulas que reforçam a missão da Febrasgo em promover educação e atualização científica. Nosso objetivo é fornecer informações confiáveis e diretrizes, sempre com foco na valorização da saúde da mulher. Eu sou Karina Adame, membro da Comissão Nacional de Especialidades de Reprodução Assistida da Febrasgo, e hoje abordaremos um tema de grande relevância. Faremos um up-to-date em tireoide e reprodução humana. Para tanto, teremos uma convidada internacional e tentaremos realizar uma tradução simultânea, oportunizando o melhor atendimento a todos. Welcome to Febrasgo Play, a series of classes that reinforces Febrasgo's mission to promote education and scientific up-to-dates. Our goal is to provide reliable information and guidelines, always improving and valuing women's health. I'm Karina Adame, member of the Febrasgo's National Committee for Assistance Reproduction, our Brazilian Federation of Gynecology and Obstetrics Association. Today, we will address a very relevant topic, up-to-dates in thyroid and human reproduction. Agora, tenho o prazer de apresentar as nossos convidados de hoje. Now, I am pleased to introduce our guests for today. Doutora Rívia Lamaita, conhecida de todos nós, será a nossa moderadora. Doutora Rívia é a nossa presidente da CNE de Reprodução Assistida da Febrasgo. Muito bem-vinda, Rívia. Dr. Rívia is our chair at the Febrasgo's National Committee of Assisted Reproduction. And I also want you to introduce you, Professor Pierce. Eu vou introduzir para vocês agora o currículo da nossa palestrante, que é a professora Elizabeth Pierce. Ela é professora de medicina e diretora do programa de residência em endocrinologia da Faculdade de Medicina da Boston University, na seção de endocrinologia, diabetes e nutrição. Professora Pierce foi graduada em medicina pela Universidade de Harvard, fez sua residência em medicina interna no Beth Israel Deaconess Medical Center. Ela é especializada em endocrinologia na Boston University, presidente da Associação Americana de Tireoide nos anos de 2018 e 2019, coordenadora regional para a América do Norte na rede global de iodo, a Iodine Global Network. Ela também é editora adjunta do Journal of Clinical Endocrinology and Metabolism e editora associada de outros periódicos como Endocrine Practice, Clinical Thyroidology e o periódico muito utilizado por muitos de nós, a Thyroid. Ela co-presidiu o grupo de trabalho na elaboração das diretrizes sobre tireoide na gravidez da Associação Americana de Tireoide em 2017, uma referência para todos nós que trabalhamos nessa área. É membro da equipe atual de revisão desta mesma diretriz e do painel consultivo de diretrizes da Organização Mundial de Saúde para a avaliação do status nutricional de iodo nas populações. Suas áreas de interesse em pesquisa são suficiência de iodo na dieta nos Estados Unidos, função tireoidiana na gravidez, efeitos de agentes ambientais, os chamados disruptores endócrinos, na tireoide e os efeitos cardiovasculares de alterações tireoidianas durante a gravidez. A professora Elizabeth Pierce, ela já foi premiada por suas contribuições excepcionais na pesquisa clínica da glândula tireoide pela Associação Americana de Tireoide e foi considerada a mulher do ano em 2018 na área da tireoidologia. É com imenso prazer que eu convido a minha mentora, querida professora Pierce, para partilhar um pouquinho da nossa vivência com vocês e com todos os nossos colegas ginecologistas e obstetras do Brasil. Com vocês, professora Pierce. Professor Pierce, the floor is totally yours. Thank you so much to be with us.
Thank you. It's my pleasure to be here. Give me just a moment to make sure I can actually share my slides.
Enquanto a professora Pis vai preparando o compartilhamento, pessoal, para vocês saberem, ela vai falar num primeiro bloco sobre tireoides e cuidados na pré-concepção, tireoide e cuidados na pré-concepção. Em seguida, ela vai trazer um segundo bloco com tireoide e reprodução assistida. E, por fim, um bloco sobre tireoide, gestação e resultados perinatais. Professor, please.
Okay, can you see my slides and hear me?
Yeah.
Perfect.
Totally
okay.
fine.
So I've been asked to cover a lot of ground in the next 30 minutes. And what I'd like to do is to give an overview of how we think about thyroid disorders, both preconception and during pregnancy. It's important to preface this by noting that we have guidelines from the American Thyroid Association published back in 2017. These are getting fairly dated. There's been a lot of new evidence published since the time of that last guideline. And I am happy to say that we have a new one coming very soon, probably in the first 2 or 3 months of 2026. This is in the very final stages of revision. So look for it in the journal Thyroid soon. So important caveat is I'm going to share a number of changes that are going to be happening with this upcoming guideline. But please bear in mind, as of right now, this is all still draft guidance because nothing is 100% finalized. So with that, again, I want to walk through how we think about thyroid disorders in the setting of patients presenting with infertility, both thyroid dysfunction and thyroid autoimmunity, and then how do we manage both hypo and hyperthyroidism, both preconception and when a woman is actually pregnant. So the infertility piece, this comes up fairly commonly. It's fairly frequent, I think, that women are diagnosed with thyroid disorders for the first time when they present with difficulty with conception. And these are data from Rima Dillon-Smith suggesting that if we were to test thyroid function in all pregnant women all women who are presenting for infertility care, we would find about 0.2% have overt hypothyroidism, about 0.3% overt hyperthyroidism, and then more with subclinical, with milder forms of these disorders. So about 2.5% would have subclinical hypothyroidism, 1.3% subclinical hyperthyroidism. And actually the biggest category, if people are testing for this, is that almost 10% might actually be thyroid peroxidase antibody positive. So who should get tested? This is something that has shifted back and forth with some recent guidelines, and there are some discordance in what recommendations are out there right now. But the ATA recommendation in the upcoming guideline is going to continue to recommend that for all non-pregnant women who present with infertility, we should get a TSH test. This does not rise to the level of a recommendation. We don't have randomized clinical trials to inform this statement. So if you look at the tables, this is a GPS, a good practice statement, basically a consensus statement that's not based on trial data. But the reasoning behind this is that if we find that 0.5% of women with overt thyroid dysfunction in the course of their infertility workup, that may be the underlying cause of their infertility. So we certainly don't want women getting pregnant with overt thyroid dysfunction that we don't know about that leads to adverse outcomes for the pregnancy, but it actually may improve their likelihood of getting pregnancy without other interventions if we find the overt thyroid dysfunction and treat it. TPO antibody testing, we said, may be performed in women who present with infertility. This is a low quality evidence-based recommendation. And as I'll note in a couple of minutes, the purpose of this, based on current evidence, is not to alter treatment decisions. It's really to determine which patients may need more frequent monitoring. For women who are on levothyroxine preconception and who have infertility, we would recommend targeting a TSH in the lower half of the reference range during both preconception and pregnancy. That is not a change from prior guidelines. And in somebody who is on levothyroxine, who's going to undergo controlled ovarian stimulation, we would recommend checking the TSH, 6 to 12 months prior to the controlled ovarian stimulation, just to make sure that thyroid function is normal before somebody goes into an IVF cycle, but then not to check again until 2 weeks after the positive pregnancy test. The reason for that timing is that if you check the thyroid function testing immediately after controlled ovarian stimulation, the results of the testing are very challenging to interpret. The HCG that's given for that stimulation drives a big spike in estrogen, as you know, and that may actually also provide a bump in the TSH level. So it's better to repeat the lab testing if you need to 2 weeks after positive pregnancy test when some of these perturbations just from the IVF hormones have resolved. The rationale for why we want TSH in the lower half of the reference range in women who are on levothyroxine already preconception is not based on trial data. It's really based on observational data sets. This is the largest study to date that has looked at this. It's almost 6 million mother-child pairs from China. And they looked at the maternal TSH within 6 months before a woman became pregnant. And then they looked at a whole host of different obstetric outcomes. And what they saw for all of the outcomes they looked at, I'm not showing all of them here, I'm just showing preterm birth, perinatal infant death, small for gestational age, but for all the outcomes, they saw the same J-shaped relationship where women with a TSH that's too low, but also a woman with a TSH that's too high in this preconception period seem to be at a higher risk for obstetric complications. So based on these data and based on the data from other similar cohorts, it looks like we should probably be trying to keep the TSH in the bottom half of the normal reference range preconception. This is not a trial. So this is not an argument that we should test every patient and institute levothyroxine therapy if the TSH is above 2.5. But for those women where this is already under our control, who are on thyroid hormone replacement anyway, this is the range to target. So when we find one of the small proportion of women who are overtly hypothyroid in the course of an infertility workup, it's recommended, again, not based on trial data, but sort of recommended based on common sense, that it is reasonable to delay fertility treatment until euthyroidism is restored. Again, partly that's because perhaps the infertility in this case will be due to the uncontrolled hypothyroidism, but also because uncontrolled overt hypothyroidism is associated with worse obstetric outcomes. So we should treat with levothyroxine for these patients. We should optimize the thyroid function, normalize that TSH, get it below 2.5 preconception ideally. And one thing that is not changing in upcoming guidelines from prior guidelines from the ATA or from ACOG is that the recommendation is that preconception and in pregnancy, any woman who's being treated for hypothyroidism should be treated with levothyroxine alone. Other thyroid hormone preparations, including T3 or desiccated thyroid preparations, should not be used preconception or during gestation because although the T3 portion of those preparations does cross the placenta, it does not seem to get into the fetal brain and it risks fetal hypothyroidism. So that's overt hypothyroidism. That's pretty straightforward. But what's been more complicated to understand is, do we need to treat subclinical hypothyroidism preconception? Again, subclinical hypothyroidism is a scenario where the serum TSH is elevated, the free T4 is normal. Here we do not have good trials. We have a very, very tiny trial with only an N of 64 infertile women who were randomized to low-dose levothyroxine, started before IVF and continued throughout pregnancy. And compared to the group who were not treated, the women who got the levothyroxine, in fact, had a lower miscarriage rate and a slightly higher live birth rate per cycle. But this is based on 64 women. It is really not an adequately powered trial, and we don't have adequately powered trials in this space at this point. So guidance from the ATA looks somewhat similar to the overt hypothyroidism in some ways. So if we newly diagnose mild hypothyroidism preconception, one may wish to initiate levothyroxine and defer pregnancy until thyroid function is normalized, but you don't have to. You can also opt just to repeat the TSH after not instituting any therapy after 4 to 6 weeks, because very frequently, very mild TSH perturbations may actually resolve on their own. So that is another option, would just be to wait and watch. If the TSH is above 10 when you first check, we would say those women should be treated with thyroid hormone. That is not based on trials in the preconception setting, but that's based on the fact that we would treat those patients outside the pregnancy or preconception setting, and there's no reason not to treat them just because they're planning gestation. So in somebody where we wait and watch and opt not to treat, if that TSH normalizes without any intervention, it probably is helpful to have a TPO antibody measurement, because if somebody's TPO negative and the TSH is normalized, they probably don't need any additional special monitoring for thyroid function once they're eventually pregnant. But women who are TPO antibody positive, even if they're euthyroid at the baseline preconception or an early gestation, are actually at very high risk for developing overt hypothyroidism as pregnancy progresses. And we don't want women to have overt hypothyroidism that's not treated once they conceive. So the recommendation is that if somebody's TPO antibody positive, even if the thyroid function has normalized without intervention, should probably keep an eye on the TSH every 3 to 6 months preconception, and then in pregnancy, probably every 4 to 6 weeks for the first half of gestation. And if you opt to just initially treat, or if you opt to treat after waiting to see if the TSH is persistently elevated, the goal would be to normalize that TSH to get it less than 2.5, and you can usually use a pretty low dose of thyroid hormone to get there. Subclinical and overt hyperthyroidism, the other end of the spectrum in the infertility setting. Subclinical hyperthyroidism does not typically require intervention. It can just be confirmed by repeating a TSH after 4 to 6 weeks. Again, it very often resolves on its own, and probably just needs monitoring if the hyperthyroidism remains subclinical. But overt hyperthyroidism really does need to be addressed preconception based on the underlying cause. Most often in women of childbearing age, that underlying cause is going to be Graves' disease. So the algorithm from the draft guidelines suggests that if somebody's has hyperthyroidism preconception, if it's subclinical hyperthyroidism, and might just opt to monitor for a little bit and see if this resolves without therapy, you can consider starting low-dose propylthiouracil, but I actually honestly don't typically do that in my own practice. We should monitor the thyroid function. If euthyroidism is restored naturally, just go ahead with pregnancy. If persistent hyperthyroidism is present, it's okay for a woman to go ahead and try and conceive, but need to continue to monitor and then to treat if somebody becomes overtly hyperthyroid. Again, the distinction between overt and subclinical disease, meaning that overt hyperthyroidism is a low TSH with elevated T4 or T3, whereas in subclinical hyperthyroidism, the TSH is low, but the peripheral thyroid hormones are normal. In somebody who is found to have Graves' disease preconception, this requires some special considerations, and I think a lot of patient-centered conversation. So for me as an endocrinologist, anytime I am diagnosing somebody with Graves' disease who might at some point become pregnant, I need to have a conversation about their plans for pregnancy, about what they would want to do in terms of treatment, and how planned pregnancy might impact choices of therapy for their hyperthyroidism. Women who are on methimazole for Graves' disease should be switched to propylthiouracil prior to pregnancy. Current guidelines say that. The upcoming guidelines are going to say that too, because methimazole is not necessarily entirely safe in the first trimester of pregnancy, and I'll show you those data in a moment. So how about thyroid autoimmunity and infertility? This is actually a little bit more straightforward because this is a place where we have good randomized clinical trials that are recent. So we have a number of observational data sets. This is a meta-analysis that suggests that even in women with normal thyroid function, TPO antibody positivity is associated with a lower likelihood of live birth compared to women who are TPO antibody negative. We also know that the TPO antibody positivity, even in women with normal thyroid function, is associated with higher risk for miscarriage and higher risk for preterm delivery. We now, though, in the last several years, have 3 large randomized clinical trials that have explored whether treating these TPO-positive euthyroid women preconception with levothyroxine improves outcomes of pregnancy or improves likelihood of conception. So the first of these trials is this one. This is called Postal, was done in China. They screened 32,000 women before IVF treatment, and women who were euthyroid with positive TPO antibodies were randomized either to low-dose levothyroxine, started preconception, continued to delivery, or to no treatment. 300 women in each group were randomized, and there were no differences with treatment in rates of clinical pregnancy, miscarriage, or live birth. That was followed by this trial done in the UK, led by Rima Dillon-Smith, with a somewhat similar design. This is Tablet. They screened 20,000 women pre-conception who either had a history of miscarriage or infertility, women who were euthyroid and TPO antibody positive, again, randomized to low-dose levothyroxine, started preconception, continued to delivery, or placebo. Their primary outcome here was live birth at least 34 weeks gestation, and they saw no effect of the intervention. And then we have one more trial, this one done in the Netherlands, published in 2022. This is called T for Life. This one is a little bit smaller, and it was halted prematurely because they had trouble recruiting subjects for the study. But here they recruited women who were TPO antibody positive, euthyroid, and had at least 2 pregnancy losses, randomized to low-dose levothyroxine versus placebo. What you see here in the plot is the median time to conception leading to live birth. And although this was not a fully powered study, I think you can see that there's really no difference in those curves. So effectively, probably another negative trial. That's the intervention that's been studied the most. There are 2 tiny trials that have looked at treating these TPO positive women with glucocorticoids. This one randomized just 60 euthyroid TPO positive women to prednisolone starting at oocyte retrieval and continuing through the first trimester compared to no treatment. There was a significant improvement in clinical pregnancy rate, but no effect on live birth rate or miscarriage. There's an even smaller trial, only 48 individuals, here not before IVF, but before IUI. Women randomized, again, to prednisone, started preconception, and tapered over 4 weeks versus placebo. Here there was no effect on pregnancy rates, and if anything, the miscarriage was a little bit higher in the treated women. And unequivocally, based on these very, very tiny trials, it would not be appropriate to recommend that the 10% of women out there who are TPO antibody positive in the population of women who are undergoing infertility treatment should get glucocorticoids. So the recommendation is not to do that, but perhaps other trials down the road will explore that better. So recommendations here are changing from the prior guideline. The upcoming guideline will recommend specifically against treating TPO positive women with levothyroxine, which just doesn't seem to make a difference. We're recommending against the other interventions that have been studied, the glucocorticoids, which I showed you, also against selenium supplementation or intravenous immunoglobulin, which have also been studied in small trials and not shown to be of benefit. So now moving on to patients who are actually becoming pregnant. Once they're pregnant, how do we manage the thyroid dysfunction? Overt hypothyroidism is not controversial. So for new maternal onset overt hypothyroidism in pregnancy, we're basically going to treat with levothyroxine. The only small caveat in the upcoming guideline is if it's a very mild TSH elevation, less than 6, it's probably okay to watch for a week or 2 and repeat just to make sure that wasn't lab error. But otherwise, in general, we're going to treat all these patients with levothyroxine. We're going to try and get the TSH less than 2.5. For women on levothyroxine pre-conception, they are going to need a dose increase in most cases to remain euthyroid as pregnancy progresses because requirements for thyroid hormone are higher. So typically we'd recommend increasing levothyroxine dosing by 25 to 30% empirically as soon as pregnancy is confirmed, monitoring that TSH every 4 weeks in the first half of pregnancy. Goal in pregnancy is that TSH less than 2.5, and it's perfectly fine to resume the preconception pregnancy dose after delivery. What is controversial, what we understand less well, is whether or not we need to treat women with mild forms of hypothyroidism once they're pregnant. Those mild forms of hypothyroidism are subclinical hypothyroidism and something called isolated maternal hypothyroxanemia, which is a normal TSH but a low free T4. We have 2 large trials that have looked at the effects of levothyroxine therapy in these mildly hypothyroid women, both published in the New England Journal. This is the first of them. This was done in the UK and Italy. They screened 22,000 pregnancies in order to randomize either to a strategy where women had thyroid function tested in early gestation and levothyroxine initiated if either the TSH was in the top 2.5 percentile or the free T4 in the bottom 2.5 percentile. So effectively subclinical hypothyroidism or isolated hypothyroxanemia. The controls were women where blood was drawn at the same time point, but not actually measured for thyroid function until after delivery, so they got no treatment. They followed children out to 3 years of age, measured IQ as the primary outcome of the study, and saw no effective treatment. So a negative trial, but one that has been criticized because the intervention did not start till at least about an average of 13 weeks gestation. And we do think that the effects of maternal thyroid hormone on the developing fetal brain, probably the most critical window for that is the first trimester. So the study might actually have been too late. The second trial had a somewhat similar design. This was done at multiple centers across the US, funded by the NIH, led by Brian Casey. Here they screened 100,000 pregnancies in order to randomize women either with isolated hypothyroxanemia or with subclinical hypothyroidism to low-dose levothyroxine or placebo. They then followed children of these women out to 5 years of age, tested IQ as a primary outcome, and saw no difference. So again, no effect on fetal development of the levothyroxine for the mild hypothyroidism. But the same important caveat here that the mean gestational age was 17 weeks at randomization. If the first trimester is a critical window for this, that might have been missed. And we don't have any trials that initiated therapy earlier in gestation. This is what we're recommending doing in the upcoming guideline, and this does represent a little bit of a shift from the prior guidelines. So if that TSH is elevated in pregnancy, in some cases it may be helpful to check a TPO antibody. In anybody where the TSH is greater than 10, just start levothyroxine. If the TSH is elevated and the free T4 is low, just start levothyroxine unless the TSH is between 4 and 6, in which case I kind of think it's lab error and you might want to just confirm it. In somebody who is subclinically hypothyroidism, you can either initiate low-dose levothyroxine, that is not wrong, or you can wait for a week or 2 or 3 and repeat the TSH level, because in a surprisingly large proportion of women, actually the TSH will normalize if it's only mildly elevated if you do nothing. But if you opt not to start levothyroxine, this should be monitored. We need to make sure these women don't develop overt hypothyroidism. The TPO antibody status, again, is somewhat helpful here just in determining closeness of monitoring, that the women with the TPO antibodies are maybe a bit more likely to develop the overt hypothyroidism as pregnancy progresses. And if we're starting levothyroxine, again, you're going to check a TSH every 4 to 6 weeks in the first half of gestation. Isolated hypothyroxanemia, we don't recommend treating. We didn't recommend that with the last guideline. We're not recommending that one with the upcoming guideline either. And that is largely because we have no trials in the literature at this point suggesting that there's a benefit of treatment. So the recommendation is don't treat. The strength of the evidence for that is actually stronger in this after the first trimester, because we don't, where we have trials that show no effective treatment, where we don't have trials in the first trimester. And something I actually failed to mention on the prior slide, but that's probably important to point out, is that what you do with subclinical hypothyroidism may differ depending on when you find it. There's probably no benefit of treatment in the second or third trimester. We could just monitor those patients. So if you're going to start levothyroxine for mild hypothyroidism in gestation, if it's past the first trimester, is probably not going to be of any benefit. Finally, hyperthyroidism in pregnancy. This is reasonably frequent in early gestation, and it's important to remember that outside the pregnancy setting, the most common cause of hyperthyroidism in women of reproductive age is Graves' disease. But in the first trimester of pregnancy, the most common cause is not Graves', it's actually this entity we call gestational transient thyrotoxicosis, or GTT. This is HCG-mediated hyperthyroidism. Circulating HCG stimulates the TSH receptors on the thyroid and turns the thyroid on. In most women, this results in just a transient mild decline in TSH in the first trimester. But in some women, especially in women with multiple gestations or other people with higher serum HCG levels, it can actually cause hyperthyroidism. These patients usually also have pretty significant nausea and vomiting because, of course, that's also mediated by HCG. If we see a patient with this gestational transient thyrotoxicosis, we don't typically treat this with anti-thyroid drug. Typically, this just needs monitoring of thyroid function and supportive care, usually just management of the nausea. But we do really importantly need to distinguish what the underlying cause of hyperthyroidism is when it happens in early pregnancy, because women with Graves' disease truly do need treatment. So we've got some clinical clues. The thyrotoxic symptoms are often more severe in Graves' disease than in GTT. If somebody has thyroid eye disease on exam or a big goiter with a bruit, you know you're treating Graves. The ratio of T3 to T4 is often a bit higher in Graves. But honestly, the easiest way to make this diagnosis these days is by measuring the TSH receptor antibodies. So that can be a TRAB, it can be a thyroid binding inhibitory immunoglobulin, it can be a TSA, thyroid stimulating immunoglobulin, whatever measure your lab has. But those assays now are very sensitive and specific and can usually make the distinction between these disorders. So the algorithm from the guideline is if the TSH is persistently low in pregnancy, less than 0.1 would be considered low in pregnancy. The TSH, especially in the first trimester, may be a little bit lower than outside the pregnancy setting. Subclinical hyperthyroidism, we just watch. That does not seem to impact pregnancy outcomes, and it mostly is not symptomatic. So that would just be monitored. But for overt hyperthyroidism, check that TRAB titer, figure out if this is Graves or not. If it's Graves, you need to treat that, and I'll show you how to do that in a moment. And if it's gestational transient thyrotoxicosis, just monitor, but likely the thyrotoxicosis will resolve on its own. If we're treating for Graves' disease, close follow-up is needed. Probably a team management approach is needed with obstetrics, maternal fetal medicine, endocrinology. The goal of medical therapy for this is to target a free T4 at or just above the upper limit of normal, because actually the fetal thyroid, once it starts to function in the second half of pregnancy, is more sensitive than the maternal thyroid to these drugs, and you need to be very careful not to overtreat the mother. And then, as I'll show you in a moment, and as obstetricians in this group know far better than I do, fetal ultrasound monitoring is an important mainstay of this care as well. We need to treat with anti-thyroid drug when hyperthyroidism is severe in the first trimester of pregnancy, but there's not a completely safe anti-thyroid drug in early gestation during organogenesis. We've known for decades that methimazole causes birth defects, but this registry study from Denmark, which had 800,000 mother-child pairs, published back in 2013, demonstrated that actually PTU also is associated with birth defects, although the birth defects associated with PTU are both less frequent and less severe. A more recent Korean registry study with almost 3 million mother-child pairs found the same pattern of these two types of birth defects associated with early pregnancy exposure to anti-thyroid drug, although the absolute risks they saw were slightly lower than in the Danish study. And I typically quote these numbers to my patients in assessing risk. So for every 1,000 live births, in women treated with methimazole compared to women without that treatment, you'd expect to see about 17 additional birth defects. With PTU, that number is about 9, and again, the birth defects are not as severe. But in women who are treated with both of those, if you switch from one to the other in the first trimester, they seem to have children at risk for both sets of birth defects. So what to do about this? The upcoming guideline is going to say that we should use PTU for initiating treatment of anti-thyroid drug for hyperthyroidism before week 16 of pregnancy. As I've told you already, if this is diagnosed preconception and somebody's planning pregnancy, PTU is a preferred drug. If somebody's taking methimazole, you can consider switching her to PTU once she's already pregnant. But we don't really know risks and benefits of that approach. We don't have trials to determine what the right approach is. And it may depend a little bit on timing. You know, if somebody doesn't present for their antenatal care until 12, 13 weeks, it may not make a difference anyway. And of course, if you're in a region where PTU is not available, then we use methimazole. And with either of them, use the lowest possible dose because we want to be careful not to overtreat the fetal thyroid. And then finally, the fetus can become hypothyroid due to the anti-thyroid drug, but the fetus can also become hyperthyroid once its own thyroid is working based on the maternal Graves antibody that crosses the placenta. So in any woman who has Graves' disease who's being treated with anti-thyroid drug in a current pregnancy, or who has a history of Graves' disease and has had her thyroid removed with radioactive iodine treatment or thyroidectomy, we need to monitor for risk of fetal thyroid dysfunction. And so the recommendation in the upcoming guidelines, the same as the last one, test that TRAB titer at the first antenatal visit. If it's less than 3 times the upper limit of normal, at that point, you're done because those titers just decline as pregnancy progresses. But if it's high initially, repeat that at week 18 to 22, which is when the fetal thyroid can start responding to the antibody, alert maternal fetal medicine, and monitor the fetus closely at that point. And, if still high at 18 to 22 weeks, check again at week 30 to 34. And that's when you may want to alert neonatology about risk for a neonate who might have hyperthyroidism. So in conclusion, I would note that overt hypothyroidism preconception and in pregnancy always requires treatment. We can consider treatment of subclinical hypothyroidism depending maybe both on the TSH level and the timing, but we have much less certainty about whether that benefits fertility outcomes and benefits pregnancy outcomes. What we do know with a fair amount of certainty based on recent trials is that women who have normal thyroid function but are TPO positive do not benefit from levothyroxine therapy. But if they're TPO antibody positive, we need to monitor their thyroid function in gestation because they are at risk for developing overt hypothyroidism, which would require therapy. When hyperthyroidism shows up for the first time in early gestation, we need to differentiate between Graves and gestational transient thyrotoxicosis. We always need to consider both maternal and fetal effects of our therapy. And in any woman with known thyroid dysfunction in the preconception setting, preconception counseling about risks and benefits of all of these approaches is very essential. So with that, thank you for your attention.
We want to thank you, Professor Priest, for this great overview. Please, Hivia, could you stay with us now?
Yes. Hello, Professor Pierce. It was a fantastic presentation. Thank you so much for sharing all this knowledge with us about the topic of thyroid and human reproduction. We have some questions from our participants about the topic, and I would like to hear your opinion. First, about the thyroid and care in preconception. One doubt is universal screening appropriate in preconception? What do you think about it?
Nobody knows the answer to that. I wish I had an answer, but nobody has an answer. We don't know. And really, whatever you do in your own practice is in line with somebody's guidelines. In China, everybody gets screened preconception. That's true in some settings. In some settings, the recommendations are nobody should get screened. We don't know. And the reason we don't know is that most of the time we think the overt thyroid dysfunction comes to attention due to symptoms, and we're not sure what to do with the subclinical hypothyroidism, which is mostly what you're going to find if you look at everyone.
Yeah, that's good. And what would be the risk profiles do you think about?
Risk profiles for somebody having thyroid dysfunction? Yeah, that's important. So anybody with most of this thyroid dysfunction that would require treatment is autoimmune. So anybody with a personal or family history of any autoimmune disorders, anybody especially with a family history for thyroid autoimmunity, any women who have had radioactive iodine treatment or partial thyroidectomy who may still have thyroid function are still at risk for developing hypothyroidism as pregnancy progresses. So I think the family history is really important to ascertain. And then on exam, anybody with a goiter, that's probably somebody you want to be checking thyroid function in.
Okay, that's good. Do you think is there a cutoff point for treatment?
Of subclinical hypothyroidism?
In preconception?
So preconception, I would use the normal reference ranges. We don't have to use pregnancy-specific reference ranges, of course, when somebody's not pregnant yet. And outside of the pregnancy setting, we treat overt hypothyroidism. We always treat overt hyperthyroidism, and that treatment of overt hyperthyroidism, usually it's Graves' disease in women of reproductive age, but depends on the underlying etiology. We don't typically treat subclinical hyperthyroidism. And subclinical hypothyroidism recommendations are, again, we don't have good trials outside the pregnancy setting either. So typically we would definitely treat somebody when the TSH is greater than 10. That's based on epidemiologic data linking that to higher cardiovascular risk and also higher risk of conversion to overt hypothyroidism. But when that TSH is in the 5 to 10 range in preconception, you don't have to treat. We would treat if there are symptoms. I myself am inclined to treat those patients because pregnancy is kind of a stress test for the thyroid, and it's likely that they might become hypothyroidism as pregnancy progresses, but you don't have to as long as you're monitoring.
Okay, that's good. And what is the treatment goal during this period? What do you think?
Yeah, so the treatment goal for hypothyroidism, if you're committing to levothyroxine, you're going to target the TSH, and that TSH preconception should be within the normal range, but less than 2.5, sort of lower half of the reference range. That's really the same reference range we'd recommend during conception too in somebody who's on levothyroxine. Upper limit of TSH in pregnancy is probably about 4, but you don't necessarily have to treat to that target. For hyperthyroidism, for overt hyperthyroidism, the goal is really normalizing the peripheral thyroid hormone levels. And preconception, that's just normal in the normal reference range. But during pregnancy, it's a free T4 at or just above the upper limit of normal, because we're more worried in that setting about overtreatment of the fetus.
Thank you. And Karina, would you like to make any comments about thyroid and preconception? We are not hear you, Karina.
Okay, so I'm going to thank again Professor Pierce, because here in Brazil, we see a lot of overtreatment. So to point these cutoffs and also establish that 2.5 is like a goal and not the cutoff for diagnose is very important, because our guideline at FEBRASGO says that we have the goal for TSH in 2.5, and people get some mistakes about this. So people overtreat. It's important to take this clear.
Yes, and that's confusing. That's confusing to a lot of people, that the old guideline and the upcoming guideline, we recommend that in pregnancy, as I said, the upper limit of TSH is about 4, so a little bit lower than outside the pregnancy setting in early gestation. But when we treat, we target to that TSH less than 2.5. And the idea behind that is just that if you're going to commit to treating, you don't want to undertreat. Rather err on the side of a little bit of overtreatment of hypothyroidism rather than undertreatment, given the potential importance of that thyroid hormone in the fetal brain. But we would not recommend initiating levothyroxine when that TSH is in the range of 2.5 to 4. There's no evidence for benefit there.
Perfect. That's the point.
That's a good point. Now moving from the thyroid and assisted reproduction, we have some questions too, like can assisted reproduction treatments modify thyroid parameters? What do you think about it?
They do, and I showed you fairly briefly a slide on that, but absolutely, especially the HCG, which spikes estrogen. That spike in estrogen will drive down the TSH. It may drive up or down the free and total T4 levels, kind of depending on where you are. And it makes the thyroid function test interpretation really challenging. And we didn't really know what to tell people in the guideline about, how to monitor that. But all of us on the guideline committee said, I don't really understand how to interpret the results if you check too soon after that HCG injection. So the recommendation is probably not check immediately after, because you might not know what to do with the data, because definitely the regimen itself for the IVF will alter thyroid hormone parameters.
Okay, that's good. And what is the current monitoring approach?
So if we're talking about hypothyroidism, in somebody who's treated or somebody who you're monitoring where you think they're at risk for developing overt hypothyroidism, like somebody who's TPO antibody positive but not on therapy, the recommendation is to check every 4 to 6 weeks, I think really every 4 in the first half of pregnancy. That is the time period when thyroxine binding globulin levels are climbing, when HCG is stimulating the thyroid, and when if you're going to see sort of a decrease in thyroid function and increase in thyroid hormone dose requirements, that's when you're going to see it. After mid-gestation, probably recommend checking, once around late second, early third trimester. Then I like to check again the next time, about 6 weeks post-delivery. And in somebody whose levothyroxine has been increased for gestation, at the time of delivery, you can put them back on the pre-pregnancy dose, but just need to make sure you're checking 6 weeks after to make sure that's still the right dose for them. Hyperthyroidism is trickier and probably needs closer follow-up. So in early gestation, often when somebody has mild hyperthyroidism, I'm watching every week or two to sort of get a sense of trends. And because I want to make sure if they become overtly hyperthyroid due to Graves' disease, that I'm going to catch it early. Because they're fairly catastrophic pregnancy outcomes with untreated overt hyperthyroidism. We want to always avoid that. So if it's, and in hyperthyroidism, again, we're trying to titrate that anti-thyroid drug to give the lowest possible dose. Often Graves gets worse in the first trimester, but that improves over gestation as sort of immune tolerance sets in. So often it's kind of a very dynamic thing. That dosing may be a moving target, and how often you need to check in hyperthyroidism may depend on the severity of the hyperthyroidism and how quickly things are shifting. But I would say probably in early pregnancy, as you're managing this, even as much as every 1 to 2 weeks if things seem like they're changing, and probably at least once a month for the remainder of gestation.
Okay, that's good. And is there any ideal cutoff point for treatment in this scenario, do you think?
So for who you initiate treatment in?
Yeah.
Yeah. So for hyperthyroidism, really it's the overt hyperthyroidism. It's when the TSH is low and the free T4 is elevated. If it's elevated more than, if it's just above the upper limit of normal, that's what we'd be treating to anyway with the anti-thyroid drug. But if it's beyond that, if it's really elevated, then you do need to initiate treatment. And if it's subclinical hyperthyroidism, you really don't, you just watch. And for hypothyroidism, again, the threshold above a TSH above 10, I think there's pretty good consensus. We would treat those women outside pregnancy. We should treat them if they're pregnant. In the range of 4 to 10, it's a judgment call. We don't have good data. I think you will find most endocrinologists, probably myself included, do tend to treat subclinical hypothyroidism in pregnancy when that TSH is in the 4 to 10 range, but have to acknowledge that there's not, good trial data suggesting that there's really a benefit.
I agree with you. And we have a question here, very interesting, about in cases of autoimmunity, isolated autoimmunity, what would be the best course of action? Do you?
Yeah, so if you just see thyroperoxidase antibody positivity or thyroglobulin antibody positivity, although the data are not as robust for the thyroglobulin antibody, in somebody with normal thyroid function, I think the very best evidence we have, and this is the one place where we have 3 good concordant trials, is that levothyroxine is not helpful. And we don't have evidence that any of the other things that have been looked at, again, glucocorticoids, IVIG, selenium, there's really not good evidence that any of those things are helpful either. So there's no intervention that is known to improve pregnancy outcomes, but we do have good longitudinal studies looking at women who are euthyroid but TPO antibody positive, and that's the group that is at highest risk for developing overt hypothyroidism as pregnancy progresses, especially sort of in that first half of gestation as the thyroid has to work harder. So I think we stressed in the guideline that we would not treat those patients, but we absolutely would monitor those patients probably every 4 weeks with a TSH in the first half of pregnancy, just so you don't miss it if they become overtly hypothyroid.
Okay, that's good. And Karina, do you have any considerations about this topic?
Oops, need to unmute.
We're not hearing you.
It's important for us to address that in our area, in the reproductive field, people usually treat between 4 and 10 of TSH. So it's important to understand better that we don't have a consensus or good evidence on this. But most of specialists and also us and Professor Pierce teach me as well, above 4 we tend to treat because we have all the modifications in the pregnancy set, but there is not any justification to treat between 2.5 and 4 as we used to do before in the last guideline. We used to treat people with 2.5 between 4 and autoantibody positivity. But now we do not have to do this anymore. So that's the real change for us in the reproductive field.
Now I think you're muted.
Hivia, you are still without
We
your
will
mic.
wait. Sorry.
Yeah,
We
now.
will wait for the update of this important guideline. It will be very good for us to conduct our treatments, our tests, and our
Yes.
patients, I think.
Would be a good evidence for us to establish our management, because if we have only this last one, we have also these controversies to deal with. Yes.
Yes. And we have 4 more questions. I think we have time to discuss them. And about thyroid, pregnancy, and perinatal outcomes. Any special profile or care to avoid miscarriage? What do you think about it, Professor?
Yeah, that's hard because we know that TPO antibody positivity, even in the absence of thyroid function, is associated with a higher miscarriage risk. We just don't know that we have an intervention that improves that. We know that overt hypothyroidism, if it's uncontrolled, is associated with higher miscarriage risk, and that we can treat. But interestingly, in the NIH multicenter study that looked at treatment of isolated hypothyroxanemia and subclinical hypothyroidism, starting in the second trimester, of course, that's too late for most miscarriage. We don't have trials that are early enough to really know if it makes a difference. So I think we don't know the answer to whether treating subclinical hypothyroidism would decrease risk of miscarriage. But we do have the preconception data and trials for the TPO antibody positive women, which suggest that treating that group probably doesn't improve miscarriage risk.
Okay. And how to minimize risks for the fetus and the newborn? What do you think we can talk with our patients about it?
Yeah, I think reducing risks to the fetus, we're thinking about a few different kinds of risks, right? Depending on what kind of thyroid dysfunction we're managing. In treating a hypothyroid patient, we're trying to make sure the fetus has enough thyroid hormone around in the first trimester for good brain development and for optimal obstetric outcomes. So in overt hypothyroidism, the best way to optimize fetal and neonatal outcomes is just by normalizing the TSH. And women who have normalized TSH who are hypothyroid in pregnancy, they have totally normal outcomes of the pregnancies, and the neonatal outcomes are just fine. In hyperthyroidism, it's trickier because we have risk of antithyroid drug causing birth defects. We have risk of both fetal hyper and hypothyroidism, and we don't have good ways, we don't have perfect ways of assessing the fetal thyroid status. Chordocentesis can be employed, but only if you absolutely must, because there's a non-zero risk of causing fetal demise. So we monitor, and I count on my colleagues like you who are obstetricians and maternal fetal medicine experts to monitor the fetus with fetal ultrasound. And we just use all the clues we have. We try and keep the maternal free T4, again, that at or just above the upper limit of normal. So we're hopefully not making the fetus either hyper or hypothyroid. And we monitor with the fetal ultrasound to look for signs of fetal dysfunction. So fetal goiter, advanced versus delayed bone age, can help figure that out. And you can see sustained fetal tachycardia in fetal hyperthyroidism.
Okay. And what criteria are currently used to evaluate of offspring of parents with thyroid disease?
So in most cases, you don't need to do anything different. Parents sometimes ask, if I've got thyroid disease, is my child going to have that too? And most autoimmune thyroid dysfunction does not manifest in childhood. If it does manifest in childhood, it's rarely silent, and often the first thing is that the child falls off the growth curves, they stop growing, and then the pediatrician will test. So in most cases, we would recommend universal screening for congenital hypothyroidism at birth, in all parts of the world where that's available, because if you find that congenital hypothyroidism and you treat it immediately, you can reduce brain damage. But beyond that, which we suggest for all babies, not just babies of women with hyperthyroidism, probably the only group that needs a little bit closer attention in the neonatal period is the infants of the women with Graves' disease that's not perfectly controlled by the end of gestation.
That's good. And about endocrine disruptors, you have a wide field of research on this subject, don't you? I would like to you would like to comment a little on this issue.
Yeah, Karina knows about this too. Something she's also studying, that there's sort of a growing literature suggesting that there are quite a lot of chemicals in the environment that we are all exposed to, things like perchlorate, air pollution, thiocyanate from cigarette smoke, PFAS, whole long list of these things, dioxins, that may adversely affect thyroid function. And if it's going to have an adverse effect on thyroid function, we care about it most in the pregnancy setting, because that's where disrupting thyroid function has the potential to disrupt, again, the development of the fetal brain, which is very dependent on thyroid hormone in the first trimester. I would also be remiss if I didn't comment that iodine nutrition is critically important for both maternal and fetal thyroid function, that Brazil has iodized salt, and I believe that iodine nutrition is pretty well optimized in Brazil, but also important in parts of the world where there isn't that iodized salt, to make sure that women are getting adequate iodine nutrition.
That's good. Karina, do you want to comment?
Yeah. These are good comments, because here in Brazil, despite being sufficient for the iodine status, we have no control, not a good control on the endocrine disruptors exposition, Professor Pierce. So we are trying to stimulate people to be more aware about these risks. And we are talking much more about the lifestyle and all the changes that we have to do in our day by day to reduce this kind of exposition and risks. So I want to thank, because it's really a great session here, and to have you with our colleagues in Brazil. So I'm very happy to be in this session today. And I want also to thank you, Rivia, to get all this together for us.
It's been a great pleasure of me to join you. Thank you for the invitation.
Yes.
And Professor Pierce, any final comments, especially for the patients for human reproduction?
I think my comment is that thyroid function does affect reproduction. It does affect pregnancy, that we don't want to err on the side of over-testing and over-treating. But when we do truly find real thyroid dysfunction, it's very important to manage that in the pregnancy and preconception setting.
That's good. And Karina, do you have any final comments?
No, not to compliment, but only to deeply say that I'm grateful for this valuable contribution, and also put us in Brazil ahead for all these changes in treat and manage the thyroid dysfunctions. Okay, thank you so much, Professor Priest. Before the publication, okay, that's a good thing to say. Brazilians are up to date now.
Yes. Our live stream is coming to the end, and I would like to thank the colleagues for their contributions, and Professor Pierce and Dr. Karina for their availability to stay here with us and discuss this important topic. I think it's the end is coming. Okay.
Obrigada, Rívia. Obrigada a todos os colegas. Thank you, Professor Fis, once again. I want to see you much more here in Brazil another time to speak for us. So it was a great pleasure. Obrigada, pessoal. Muito obrigada pela atenção de todos.
Não percam nossas próximas aulas da Febrasgo Play. Acompanhem nossas lives no canal da Febrasgo e fiquem por dentro das atualizações e conteúdos científicos. Gostaria de agradecer a todos e desejar uma boa caminhada aí dentro da jornada da infertilidade. Obrigada.